Good afternoon. This is Elisa Ares-Babuchaga, Vice President of the AHA's Physician Leadership Forum, and I am really thrilled to have you joining us today for a presentation on Geisinger's Center for Professionalism and Provider Support. This webinar, before I introduce our speakers, just want to make sure you're aware that this webinar is approved for 1 hour of CME. At the bottom of your screen, below the presentation slide, there is a form to claim the CME, and it will also be emailed to you after the call. So just want to make sure everyone has that available. Now, I'm really pleased to have with us Dr. Charlotte Collins, Director of Geisinger Center for Professionalism and Provider Support, and Monica McCarthy, Program Manager at the Center. And I'm going to let them tell you all about the great program that they have put together and all the work that they've done. With that, Charlotte, I'll turn it over to you.
Thank you very much. Thanks to everyone for being here today. Before we get started, we want to thank Elisa and Kristen at the AHA for helping put this together and asking us to present on the center today. This all started in May when we had a regional workshop breakout session with the Hospital Association of Pennsylvania, accompanied by regional leaders interested in burnout, as well as leaders throughout the nation from CMS and AHA. So we're delighted to be here. For today's agenda, we will do some brief introductions and then go over our learning objectives. Wow, I'm already starting off that. We're going to go over our introductions and then our learning points that we want to get to you, but mostly we want to spend time today talking about our journey and having time for questions and discussion at the end. So, as I learn to go through this webinar, this is our first webinar on this platform, so bear with me if I'm not very technologically sound. My partner here is much more technologically savvy than I am. But let me introduce myself and tell you a little bit about my background and how I got involved in this center. So I came to Geisinger almost 11 years ago, and I was recruited to develop interdisciplinary teams that included psychology in order to transform care for patients with medical illnesses. We were moving toward a whole person care at the patient's point of need here at Geisinger. And this work has been extremely rewarding for me, and we've made enormous progress on this journey. Along the way, I found myself working more and more with the clinicians on my team and throughout the hospital to help them deal with the stressors inherent in the healthcare field. And we have incredibly dedicated clinicians at Geisinger who go out of their way to take care of patients, sometimes at a high cost to themselves. We've been working hard at Geisinger, as I know other healthcare systems have, to optimize performance by enhancing patient experience, improving population health, and reducing costs, the so-called triple aim. But I believe we had not focused enough on the work life of our healthcare providers, the so-called quadruple aim. And this began my slow transition from a full-time patient care and program development and integration work to a focus on the work life of our healthcare providers. I still see patients and work on interdisciplinary teams, but more than half of my time now is spent developing the center that we're going to talk about today. Through this work, I'm finding new ways to improve the healthcare experience for patients and for those who take care of them. I'm going to turn this over to Monica McCarthy so she can introduce herself, and we will be flipping back and forth today talking about the slides here as we move forward.
Thanks, Charlotte. Good afternoon, everyone. I am Monica McCarthy. I'm currently an administrative fellow at Geisinger Health System, and I serve as the program manager for the Center for Professionalism and Provider Support, as well as I also help with integration of one of our newest hospitals into our system. At my time at Geisinger, I have served as an operations manager for a multi-specialty outpatient clinic and a primary clinic, as well as partnering with leadership to spearhead an integration of primary and specialty care of our chronically ill patients and with new care delivery models. So partnering with Charlotte has been an easy transition as we both have had integration backgrounds. Prior to Geisinger, I worked in a consulting firm with new payment and delivery models and was also a coordinator for an accountable care organization. Throughout all of these diverse experiences, there's been a consistent theme of change management. We have found the underlying barriers to progress and making work towards common goals has really been the ability for teams to align, break down siloed mentality, and truly work as interdisciplinary teams. At the same time, I've really been driven to create a compassionate workplace environment, and this has all led me to partner with Charlotte and developing our Center for Professionalism and Provider Support. It has truly been rewarding as we've been able to take action to mitigate these barriers through building those interdisciplinary teams who are charged with finding new ways to improve the healthcare experience for our patients and for those who care for them. So our backgrounds have really brought us together, and we're really excited to tell you a little bit about what we've been working on. So before we get into our learning objectives, I wanted to share with you a little bit about Geisinger for those of you who might not be familiar. Geisinger is a large physician-led integrated health services organization comprised of approximately 30,000 employees, including nearly 1,600 employed physicians, 13 hospital campuses, 2 research centers, and over 500,000 member health plan located in central Pennsylvania. Geisinger services more than 3 million people throughout 45 counties in central, south central, and northeast Pennsylvania, also in southern New Jersey at our Atlantic Care campus. Recently, in 2017, we welcomed Geisinger Commonwealth School of Medicine and Geisinger Jersey Shore Hospital as our newest members into the Geisinger family. Geisinger is also widely known for innovative care delivery models, such as our fresh food pharmacy and our proven experience rewards program. Geisinger has also been repeatedly recognized for its accolades in integration, quality, and service. In addition to fulfilling its patient care mission, Geisinger has a long-standing commitment to medical education, research, and community service. So we hope some of this background gives you some insight into the type of organization we are as we continue on our journey. And we will now turn it over to our learning objectives for what we hope that you will learn today. So here are our learning objectives as you saw in the announcement. We really hope that you can leave today as you watch this webinar with a few of these in mind. We hope that you can learn and discover how Geisinger is fostering a culture change through alleviating systematic stressors that negatively impact providers, how you can better understand how a team-based approach can improve the provider experience, promote well-being, and reduce burnout, as well as learn how to build a system awareness about new initiatives to further collaborate, identify additional gaps, and mitigate duplicate efforts. We recognize that we are not alone in wanting to make changes in the culture of healthcare. We are excited to share our journey and hope it will be helpful to you as we work towards culture change in your organizations. We also would be happy to help partner with you as you start your journey, as well as learn some of your best practices.
So this is Charlotte again. So at the same time I was working with clinicians on my integrated team, I also became involved in the Physician Health Committee with Dr. Paolucci. And that's where the evolution. In this role, I was working with physicians who were struggling with personal or professional issues. It became more and more clear to us that solving problems one at a time was not the most effective approach. We began to identify many issues that were challenging for our providers and realized we needed a larger response to address all providers, not just the ones that became extremely distressed. We wanted to find out who we were missing and in what ways we could be more helpful, both reactively and proactively. And in general, what could be done to make things better for our providers across the system? As we began to talk about these issues with colleagues in our system, energy and enthusiasm began to converge around the idea of a center for professionalism and provider support. We also found out that many others were working on projects independently, trying to help clinicians in a variety of ways. So the center provided a way to bring these efforts together and tap into the synergy in our system. As you will see, the journey has been very interesting and continues to take us in new directions. We feel like there are these key advantages to focusing on the provider experience. And the first one is that when we do this, we can have a much more engaged workforce and satisfied providers. We believe that changing our culture will improve our recruitment efforts, and we will be able to retain high performers, which is important in any healthcare system, but particularly tough in central Pennsylvania to get people to come out, which seems like the middle of nowhere to some folks out there. We really want to reduce burnout and improve communication on teams. These strategies that we're using, we believe, will do that, and we know if we can, the patient experience improves, and overall, better patient care happens. We know that suboptimal care happens if providers are burned out or communication is poor between teams. So this led us on our way. So some of the work that began here came out of a lot of the literature and what we know from elsewhere about what happens if you don't invest in your people and your work environment. And we know that it can result in dissatisfaction and safety issues, that there's an increased medical errors and higher malpractice risk, that patients are less satisfied, and that these deteriorating relationships across all members of the workforce lead to all kinds of problems. We also know that the increased burnout among providers is leading to all kinds of horrible outcomes, including physician suicides across the country. We know that high turnover happens when people are in an environment that's not supportive of them. And it's not just the physicians, but nurses and all the support staff that leave when there's a caustic environment for providers. So when we wanted to start this, we really talked about investing in our people and our work environment in order to achieve our system goals. Part of this was really creating an accountable culture of professional behavior through relationship-based approaches. And we wanted to develop, organize, and disseminate resources to try to prevent and ameliorate common stressors faced by our healthcare workers. We had some of these, but they weren't well coordinated, and we were missing lots of things that we feel and are working hard to develop now. So we stopped and thought, what would an ideal culture look like? And if you know anything about Geisinger, caring is our motto. So we really wanted a caring workplace that had transparency in everything that was going on, that used strong interdisciplinary approaches and decentralized decision-making, broke down those silos, included workforce at all levels, and had an approach of continuous improvement, which I hope you'll see as we discuss our programs moving forward. Okay. So we used an Emergent Design. This was new to me, an Emergent Design approach, but it allows you to foster ideas that come from frontline staff and the people in the trenches. So it was very fascinating to us to try this design. It's a little scary, too, because you don't know where your destination is when you start. However, this is the approach we took, and we're awfully glad we did. So I want to talk a little bit about what these boxes mean on an Emergent Design for those of you who haven't heard of this before, as I had not before starting all of this. So the purpose in an emergent design is to articulate objectives and outcomes up front, because if you don't have clarity there, it's difficult to assemble the rest of the pieces for an effective collaboration. So to do this, you start at the end, imagining what the change we're trying to make will look like and laying it out in clear language in order to guide the rest of the design process. The second is the players. Once you have your purpose in mind, who are the people we need in order to achieve it? We believe that gatherings should assemble people that represent the many aspects of a system that we're trying to influence. And emergence happens when solutions are designed by a group and not for a group. The third dimension is structure. There are many elements of time and place that need to be in place in order to support an assembly of players, from the space they need to collaborate to the information they need to have on hand to be effective in their work. And the fourth dimension is process. And since we're designing for an emergent outcome, in other words, we don't know exactly what it's going to look like in advance, we have to design a process that will allow participants through active engagement to share, learn, experience, and experiment until they come up with the solutions to the problems that we identified in our purpose. The fifth dimension is facilitation. Collaboration, co-creation can be hard work, so our process design comes together. We have to imagine how it should best be supported in order to make it a little easier, and look at obstacles we can remove in order to let the best outcomes emerge. And finally, the last dimension is sharing. Because no intervention happens in isolation, we need to plan how to best share the fruits of the collaboration to the larger system in order to spread the impact. Oops. I did something wrong there, sorry. Monica's going to help me. See, I told you. Here we are. Thanks. I mentioned that technology is not my strong suit. So when you see a little blip, that's Monica straightening me out. So we wanted this design philosophy that enables shared intent and common direction, and this whole multi-stakeholder setting, which has been very interesting and I think productive for us. So we're advancing system transformation and culture change that's sustainable. We don't want to start a bunch of things that we can't continue. This bottom-up design structure is critical for us, and then these feedback loops at all stages in the process help us measure impact and help us get where we need to go. Monica.
Thanks, Charlotte. So now that we've discussed a little bit about our design structure and our philosophy and how we started to develop the ideas around what we wanted to do around our culture change, we then created this journey platform. So I'm going to walk through our journey, which has really been built on the foundation of lessening systematic stressors that contribute to burnout. And this is really our initial target. As we develop these programs and we prove to be successful, the next phase we really want to focus on is our individual training for providers and resiliency. We'll use this as our framework to walk through the rest of the presentation, using each curve as an indication of where we were at in the process and what we did. So first I'll walk you through our stakeholder and gap analysis. Then I'll talk about our resource coordination phase. We'll dive really deep into our system programs and pilots so you can hear a little bit about what we're working on specifically, and then talk about what our goal is for our system transformation. So after we set up our design, the first thing that we wanted to do is get feedback from everybody else and really listen to what what the stakeholders were saying and what the providers and the staff were saying about what we should do and how we can do things better. We did this through an appreciative inquiry. For those of you who are not familiar with an appreciative inquiry, this is a learning experience for me when I started this. Really the benefits of doing it is that it breaks open the box and it really starts with what the ideal is first. So you really mitigate people focusing on what's negative and what the issues are today. It's saying where do we want to go and what's the path and vision going in the future. It also reiterates and affirms past and present strengths and successes, as well as explores new potentials and possibilities. This really allowed us to create a plan and a path forward that strengthens our system's capacity to anticipate and also embrace new ideas that lead to increased and positive outcomes. So we sent out this survey, and it went to a lot of our leaders around the organization, but also people who are designated as an influential person, whether they are in a formal leadership position or informal leadership position. Also, we spent some time surveying all of our physician leaders as well, just to get an idea of where we should start. And this is what came out of the results. We found that the programs we currently had in place were really more on the reactive side than the proactive side. We had no centralized process to access available resources, and when the resources did exist, they were siloed and they weren't really coordinated well. Additionally, they also pointed out there were significant gaps in our proactive resources. So with that background information, we took out to really create programs starting with the more reactive and the intervention stages, but really our goal is to build up to our prevention phases that are more proactive. So now we're going to dive deep into some of our pilots and let you know how we are building from our intervention phases to our early identification and then all the way to our prevention. I will hand it over to Charlotte to start with our first intervention phase.
Okay. So one of the first things we wanted to look at were how we were dealing with lapses in professionalism, and what we found out is that we were dealing with it differently. Different people were dealing with it differently across departments and across individuals, and we weren't always effective in creating change. So we worked hard to develop a collaborative approach to create a tailored plan with built-in monitoring and feedback in order to improve behavior issues. And then we wanted to make sure that we were offering resources to help providers achieve the goals we were giving them. So this really happened when there was poor patient or team interaction. So if we identified a provider that was not doing as well with patients and patient satisfaction or patient complaints, or if teams were nominating someone that they felt was not working well with the team, then we wanted to really figure out how to help that person and help the team. And so we would work hard partnering with our leaders and the providers and human resources here to actually make this happen. It's really important to us that this be a transparent process, that we set clear expectations for those providers and the leaders, and that we are making it very clear that this is something we want to help with and we want to help them improve, and that there are resources available to them that can get them where they need to go. So now we're going to move from intervention to early identification, and I'm going to shift back to Monica to talk about that.
Yeah, so the next thing that we identified that we wanted to really revamp and work on is something we're calling provider feedback, which is replacing our provider evaluation process. And really the goal and the target and objective of this is to align our provider evaluations with our system standards, transform it to a real-time technology process, and also cultivate and develop the pathways for frequent conversations between leaders and providers. In essence, we want this to get away from an annual performance evaluation where you rush through it at last minute to get it out of the way, or maybe it can be burdensome, to really real-time useful conversations that's enacted through details as far as metrics, as far as outcomes, and how that provider is doing individually and how it aligns with the system goals. One thing that we thought was really important, a part of this to help in changing our culture, is the recognition feature. So in the technology that we're looking to implement, they have the ability for providers, for staff, for nurses, for everybody to recognize one another and give people kudos to say, hey, Dr. Smith today did an amazing job with patient Mary, and they did a really good job today, and we want to recognize how they did it. Or, on the contrary, changing our culture for people to point out coaching lessons or areas for improvement that can go to their managers and help them really have a tailored approach to how we can better manage our employees, but also give real-time feedback. A key to this is also tying in our social compact, which really outlines the expected behaviors that we are anticipating for our providers. And so aligning all that together and partnering with human resources and our physician leadership, we really hope to have an early identification system that will allow us to identify if people are struggling early on and not just that once yearly conversation and that annual feedback. The next thing that we're working on that kind of goes hand in hand with our provider feedback process is a provider dashboard. What this is it's a multi-dimensional tool that clearly highlights providers' contributions to the system goals and identifies opportunities for improvement. And we really want it to be transparent so everybody knows what's going on from the provider, from the leader standpoint. And this can be anything from patient satisfaction scores, complaints that are either solicited or unsolicited, quality indicators such as infections, chart completions, and some of the administration tasks that we all can struggle with from time to time, and also any HR issues that come up. Having this all on one dashboard to view and to discuss at the same time really gives you a whole holistic picture of the provider and their performance, as well as gives you a snapshot and a tool to discuss performance with your leaders. We also hope that this will help us early identify areas for burnout and really get to underlying issues of people who are struggling. So both the provider feedback process and the provider dashboard is part of our early identification areas that we hope will help us start to move to more prevention. And then I'm now going to hand it over to Charlotte, who will talk about all of our programs in our prevention area.
This is the most exciting part for us because our goal is to have way more prevention in order to have way less intervention. And so we've been working hard on thinking about how we do things and how we can do things differently right from the beginning. So we've designed an entire new provider orientation. It's actually fortuitous that was going on at the same time that we were developing the center. This is one of those partnerships that we said, oh, we're working on the same thing. Let's work together. And so we started to set expectations at our new provider orientation for the shifting culture. As Monica mentioned, our social compact, it includes expectations about how we treat each other and our patients, and that is discussed at length in our new orientation. So we want them to know what we expect from them, but we also have a big section on all of the center work and what's going on because we want our new providers to know what they can expect from us and how we are going to be there for them. So we've been asking them at these new orientations, what do you really want? And what we're learning is interesting, although probably not surprising, but that they want from the moment they're hired to be connected to us and feel they're an important part of Geisinger. Of course, they would also like massage chairs, as you'll see, but probably we're not going to get those. And that's okay. They do laugh when they say that. we're trying to figure out ways to meet their needs. So out of this has come several interesting ideas. One of our institutes is beginning an ambassador program where each new hire is paired with someone in that same institute, a person to touch base with, to be a contact person for questions they have. And then we're working to develop a mentoring program for the first year or so for new providers who want it, so that they have someone more than an ambassador, but someone to really mentor them through, because the first several years for providers are often the most difficult in adjusting, especially if they're coming from fellowship, but also if they're in a whole new location from where they're used to. We are also working and considering a plan where the center will have someone reach out at several intervals during the first few years to our new providers as a check-in on how they're doing, seeing if there are unmet needs, and how we can help if there are. And we're looking at how do we get our whole system involved in welcoming new people and being resources for them. And so we're even thinking about how we might identify people on their badge so that everyone knows they're relatively new to the system and can welcome them and ask them if there's anything they can do for them. So all of this is really leading us to the idea that one of our leaders suggested in a separate meeting is that the system should have provider advocates. In other words, we know we have patient advocates, and we need those, and we want to hear from those, but we probably need provider advocates when things are just not going as they hoped. And this shouldn't stop after the first couple of years of being here, but provider advocates should be available to our providers across the time that they spend with us in our organization, no matter how long you've been here. So these, again, as you will see in most of these, as it should be, these are interdisciplinary approaches, and we have pulled lots of people together to do new provider orientation and to make sure that it's dovetailing with what the message we're trying to deliver about the culture here. We also are working to fill other gaps. One of the things that we found out early on from leaders was that they didn't feel they had adequate preparation and training for some of the leadership roles that they moved into. And as we change expectations for our providers, the expectations for our leaders are shifting also. And we need to make sure that any new initiatives come with preparation for our leaders to be able to function at a high level. So this is our part of our plan for each new initiative that leaders are a part of, that we are bringing training for the leaders so that they feel comfortable and confident in rolling things out. In addition, we know the landscape for healthcare will continue to evolve, and we need to prepare future leaders to help with needed changes. So we're looking at ways we can offer further education and mentoring opportunities to meet these future needs. Many places do this. We just initiated an MBA program and are looking at other potential partnerships that could create job enrichment opportunities for our providers. Of course, we continue to look at other established programs such as Crucial Conversation, Team Steps, and Resiliency, and we're trying to figure out which ones we should offer system-wide and which ones can be options for departments to take advantage of. Okay, shifting back.
So lastly, one of our prevention programs that we're working on is physician engagement. And physician engagement can mean a lot of different things to a lot of different people. The approach that we're taking might be a little different than what you've heard of before. So we're using data analytics to analyze performance on teamwork, mutual respect, communication within and between departments, and then develop action plans to improve culture of collaborative care. By doing this, we have everybody surveying each other on how they think they're doing between their department so cardiology is ranking cardiology, but also how cardiology and lab are working. And those are just a couple of examples of the departments that are involved. We're currently doing this across 10 of our different departments at one of our campuses, and we're doing this as a pilot to see how it works on that campus and if it's something that we'd want to adopt system-wide. It's been really fascinating. This is actually one of the best practices we've adopted from one of our affiliate organizations who has been deemed best at class in some of these initiatives. And they've seen this to be very successful and something that's led to system-wide culture change for them. So we're excited to see how this comes out, and it really fosters communication, and if cardiology is having trouble with labs, fosters that communication to say, hey, what are we going to be doing differently, and how can we help, and let's have a real conversation about this and kind of sit down and talk through it. So we're really excited for that program. And last but not least, throughout all of our programs, we're also enhancing and creating more robust resources and support. A lot of these we've mentioned throughout some of the stories in our programs, including ongoing training, mentoring, burnout interventions, but other ones include lunch with leadership. So providers are regularly seeing leadership, and leadership's listening and hearing what their concerns are. It also includes litigation support for some of our providers. Unfortunately, if we ever get to that stage, that can be a very concerning time and can disengage you in the work that you're in. So we're creating a better support system there. Second Victims Program. I don't know if anybody's familiar with the Second Victims Program, but that's where, unfortunately, if there's a patient adverse event, the patient and their family is the first victim and the provider is the second victim. So how do we help wrap resources and support around them in a time that can be emotionally distressful? Coaching for lapses in professionalism, and then, of course, partnering with our employee assistance program. So these are all the different programs we're working on. This is kind of a summary of all the programs we're working on, and how you can see they range from prevention all the way to intervention. And as we continue to expand these programs and pilot them and prove to be successful, we hope to get more and more and more programs in the prevention area.
So we're on this journey that begins with our providers. We know, because as word of our center is spreading, we're hearing from many other groups about wanting these same kinds of resources for members of their workforce. So we know all employees need to be included and involved at some level, and we realize that it's going to be important for us to spread this. We're starting with providers, but we intend to spread across our system, including our medical school and residencies, administration, nursing. As we learn and evolve, we expect these ideas and this culture to spread. So after programs have been implemented and proved to be successful, of course our goal is to scale them across the system. We know the mountain seems high to us at times, and we strive for those peaks. We want to stand up there and be glad we've accomplished it. We also know that once we get to the top of one mountain, there's going to be other ones in front of us to face those challenges, and it's all about just continuing to work and transform and sustain what we can. So I'm just going to summarize this pretty quickly here. We know that investing in our people and our work environment is going to help us achieve our system goals. We know that if we don't, we've already been over these, that there's dissatisfaction, the relationships are poor, and the patient care is not good. So what we're really doing is working on building healthy and open relationships, communicating about resources available for stress management, burnout, crucial conversations, workplace abuse, conflict management, and we're developing formal policies and processes for employees to refer to when they're in need of an intervention. So we want to open it up for questions and discussions at this point. We've put, because we know these slides will go out, our contact information on this slide here. And we
Thanks so much. Very much appreciate your presentation. Taking the prerogative of the moderator, going to ask the first question. Can you tell us a little bit about what kind of leadership support and involvement you had from the system going into this development?
Well, that's a good question. We have had support from the highest levels, Dr. Feinberg and Dr. Rue, who are CEO and our overall CMO. What's interesting about their style is that they really kind of have Emergent Design in the back of their heads anyway, because they said, great idea, tell us what you need, go forth and figure out the best way to do that. And so, so far, everything we've asked for, we've gotten. We have a lot more asks coming, so hopefully that will continue along the way.
So we have a whole slew of questions in the chat box. Thanks, folks, for sending those in. The first one here is about pushback from providers regarding the level of transparency of the performance assessment dashboard, and we've gotten a few questions about how what that dashboard sort of looks like. And so as you were doing that, how did you overcome the challenges about pushback about transparency and just working, I think, even broader with the different departments to understand, how this was helpful to them? How did you get folks on board?
So with the provider dashboard, we're still in the infancy phases of developing it, but it's been a interdisciplinary team approach, as all of our programs have been. We've really gotten support from our support service team, so risk management, quality, litigation, patient experience, all of those stakeholders. But at the same time, when we've brought this up to physician leaders, and to providers, they seem to be very eager to have some transparency on how they're performing. Just because, from the day-to-day, you can get down into the weeds with trying to take care of patients. It's hard to kind of understand how you're performing holistically. So we haven't really dealt with much pushback yet. That doesn't mean that we don't anticipate to overcome those barriers. But whenever we do, we always try to take a collaborative approach to really understand what the pushback is and why, and how we might be able to either phase out the implementation of the programs to better develop them to meet their needs, or how to go back and maybe change some of the areas that they're concerned about.
And almost everything we've done here, everything, has all been piloted. And so part of our goal, and is to come to consensus about what really is good information on the dashboard and that we really need, and so we don't overload it with stuff but get the key variables. And then we will likely take an institute or even a department within an institute and pilot this and get feedback from not just leaders but providers about how this goes. And the dashboard itself is, the transparency of that is really between leader, how we envision it is really between leader and provider. It's not something that everyone has access to. So we are working and being mindful of the fact that we want people to have this information, but the whole world doesn't see, your dashboard. You see your dashboard, and you may see comparison data that's de-identified or averages, but not everybody is going to look at you and your dashboard, at a department meeting, for example.
Great. So I think it's great that the work that you're doing around identifying providers at risk and trying to move that back towards the sort of prevention stage. We have a question here about, do you have plans to capture some of the systemic contributors to poor provider performance if there are specific things that keep coming up? Is there a way that you're tracking this information as it comes back into you?
Yes, this has been one of our huge initiatives here and this is part of the listening to the people on the front line. And we have a couple of people very interested in kind of the burnout from all the administrative tasks and how we just continue to add more electronic administrative tasks to doctors, which really cuts back on, and I noticed in one of the questions, really cuts back on patient care, which is a huge dissatisfier to our providers. And one of our affiliates has the motto and really tries to hold to it. If we add any administrative task, we have to take one away, and really looking at, is this really critical, and do we have to do all of these administrative tasks? And so we haven't gotten too far on that yet, but we know from what everyone would say is that burnout is not just something that happens within an individual and the individual needs to control it. It's a systemic issue, and it's a systems need to flex and move to reduce the burnout, and that is going to be a very huge ongoing focus of ours. We're doing some lean things here, and we're doing some other things to try to tighten down and not have duplicative processes, but we know that that's going to be a big issue, and we are already collecting, but we're going to get more feedback from providers on that, and that will be presented to leadership in ways that for us to help make those changes.
Great. So how do you decide, I know you said you pilot these over time, but how do you decide what initiatives are really going to go broadly system-wide, or that you're going to start, smaller at the department level and maybe not grow quite as fast? Are there any that you're rolling out, this is something everybody at Geisinger needs to be prepared to do?
Well, I think the new provider orientation is one of those things where we're talking about our social compact, and we want to let people know what's expected and then what resources are bring to bear. So I think that's one of the ones that's system-wide going out there. We need to back up and get all of that out there to our providers who've been here a while, and we recognize that. We're kind of piloting it in the new orientation to get that down pat. Other ones we're testing out, like the one that Monica talked about, where we're doing interdepartmental communication and effectiveness. This has come out of a problem with referrals, with in-system referrals, that we feel like somehow we're not getting the in-system referrals that we would like, and people are not happy with what happens communication-wise coming back. So that project and all the analytics for that, we really want to try that at a hospital and see how it goes and see where the issues are, and then suggest that or offer that to other ones.
Speakers, are you still with us?
I'm here.
Oh.
Can you hear me now?
There you go. Looks like we had lost Charlotte for just a moment.
Okay. Okay. Sorry.
I think another thing to add to that question as well is a lot when we go out and talk to everybody and get feedback, some of the programs have been very grassroots from the bottom up. And so when that comes up to them, we ask them, they said, do we think your department's ready for this? Is it the institute? What do we think your team's readiness level is? And if it's something that we think it should be scaled system-wide quickly, we do that. Other times it might be coming from leadership saying that they've heard it multiple times and that this is something we need to do system-wide more quickly. So those are kind of the deciding factors as well. Can you still hear us?
Yeah.
Okay.
Well, this is Elisa. I can still hear you, and I'm hoping we're all still working on the audio. So there's one that's not really a question here, but talking about a little bit about there are a lot of individual specific problems to solve. How are you looking at, so whether it's time spent in the EHR, I love the term pajama time, physicians, burning out on having to hit volume targets over value and so forth. How are you looking at some of those specifics, or are you hoping to sort of take a step back and provide people the supports that they need to address within their department their issues?
Well, that's complex, and there's a lot of things going on here. For example, we're in the middle of a primary care redesign that's ongoing, and so some of our efforts are, kind of working alongside that, which is a big change for us. And so everybody's dealing with this, widget versus value thing, and we're trying to, I see in one of the questions, we're trying to provide more time for the more complex patients. And so one of the things we've realized is that, not everybody's a 15 to 20-minute appointment, and that's come up through the ranks forever. And so what we've done at a system level in that is really work on partnering physician's assistant or nurse practitioners with primary care providers and having two kinds of sets of appointments, shorter ones that need shorter time and longer ones that need longer time. So some of that's being addressed in some other things that we're doing around redesign of our system and trying to get over to the value side. That being said, it's still, especially in places like primary care, really tough because there's not enough primary care providers, and it's just a tough thing to, even if they wanted to have less patients, there's just nowhere to put the other patients for us out in this rural environment. And so really talking to our providers and seeing what creative things we can come up with to help do that, and then making sure that resources, and so for example, some of these are system issues, right? So as we say, we're trying to redesign. Some of them are, provider specific issues. Like some people really manage the EHR really very well, and some really struggle. And so we've done some coaching and individual observation, and then giving people tips and helping. We've done things like some people have gotten scribes sometimes, and so we're trying to individualize it if it's an individual issue that, maybe a few people, even with redesign and so forth, still struggle, whereas the most of them, if we can make some clear redesign issues, it helps most people. But then there's always the ones that are just struggling anyway, and then we try to do individual interventions or figure out what's going on and see if we can help.
So another question that's come in, what have you found and done about the status and power differentials, not only those, but sort of the common changes, differentials between physicians and nurses? Have there been issues there that you've dealt with through the center?
I think we have a lot more work to do there. I'll start by saying that, as does every system. But I think we have a lot more to do there. We have a very strong nursing group here, and they want lots of this stuff too. They're already raising their hands, which I think is great. One of the reasons we think starting with the doctors and providers is that they really set the tone for things around here. We're a physician-led organization, and we feel like if we can make changes there, it will definitely not just trickle down, but gush down to those below them. We have done, in terms of PAs and nurse practitioner, like in our primary care, we've formed partnerships, which I think helps with that, where it's teams. They're working together to figure out who sees what patients and what's a long patient visit versus a short, and how do they work together to take care of a group of patients. And I think that helps with that differential when you can do the teams. That's different than like in hospital care and so forth that we're talking about. So we have a lot more work to do in that area for sure. We're hoping that if we can change the culture, that everyone will, for the physicians and the other advanced practitioners, that everyone will benefit, but we know that there'll be more to do.
Yeah. We've actually gotten a request, and maybe we'll connect you offline, about but do you have maybe a quick high-level sort of answer to what are those principles, what have you learned so far in terms of that assignment of the more complicated, complex patients that might need a longer visit versus a shorter visit? Are there some sort of overarching themes that you're seeing across practices?
Well, it's pretty new, so I don't know if we've got our themes yet,
Okay.
because we haven't launched it everywhere. So it's kind of rolling out, but that's something we'll keep an eye on. And whatever system change you do, and all of our stuff we're trying to do bottom up. Some of this, there's been stakeholders all coming together to help with this redesign, but then it's kind of coming down after that. So that's a little different. It's a little harder to get buy-in when you didn't have a part in it, which is why we've tried to have everybody who might be involved in our stuff a part in it. But I think in general, I've been hearing some good people feeling good about the redesign, but I wouldn't say we have themes yet evolving from that. But that's an excellent question and something we should be looking at.
Great. It looks like we've got time for one more. So how much time does the physician need to invest to participate in these activities?
Well, that varies, I think, and part of what's going to be interesting to us is that a lot of the programs that we want to develop are going to need volunteers to be a part of them, whether it's mentoring or second victims. So far, we've had people putting their hands up. We haven't yet solved all the detail about how we will provide and carve out the time so that this doesn't just become one more added thing. We actually have some retired physicians who are coming back and saying we want to work with people, we want to help. So that's kind of nice, people who were at Geisinger a long time. But as we're developing the programs and trying to meet the need, we're looking for trying to capture this as maybe a professional development opportunity for someone who really wants to coach other physicians or really wants to help. A lot of people who've been through litigation or been through a horrible adverse event say they would be more than happy to talk to somebody about that offline, even on their own time, because how horrible that was for them. And so it'll be interesting to see, because right now we're just in the piloting kind of phase. It'll be interesting to see how much volume we get, how much we can handle, and how many people are willing to be a part of that, and what kinds of other resources we need to bring to bear.
Well,
that's where our leadership needs to say yes.
Wonderful. Thank you so much. We really appreciate you taking the time. As we've noted a couple of times in the chat box, but just for everyone's information, this copy of this presentation and a recording will be available on our website, ahaphysicianforum.org, later this week, and we'll make sure we follow up on those last couple of questions. But want to wish everyone happy holidays and look for more information about our next webinar in January, coming out in our physician newsletter shortly. So with that, thanks to Charlotte and to Monica, and we're adjourned.
Thank you, everyone.
Thank you very much. Ladies and gentlemen, at this time, this conference is now concluded. You may disconnect your phone lines and have a great rest of the week. Thank you. Speakers, one moment.